Hello everyone. In this video, let's discuss about the developmental disturbances of tongue. So let's begin. The following are some of the developmental disturbances of the tongue: aglossia and microglossia syndrome, macroglossia, ankyloglossia, cleft tongue, fissured tongue, median rhomboid glossitis, benign migratory glossitis, hairy tongue, lingual varices, lingual thyroid nodule. Aglossia and microglossia syndrome. This malformation is very rare. This has no gender predilection and no genetic implications. Its etiology may be due to fetal cell traumatism in the first few weeks of gestation. It is always associated to the malformations in the extremities, especially the hands and feet, cleft palate, and dental agenesis. Aglossia syndrome is a microglossia with extreme glossoptosis. As a consequence of the lack of muscular stimulus between the alveolar arches, these do not develop transversely and the mandible does not grow in anterior direction, produced as a result of severe dentoskeletal malocclusion. Here is a picture depicting aglossia and microglossia syndrome. Macroglossia. Macroglossia is also known as tongue hypertrophy, enlarged tongue, and pseudomacroglossia. Etiology. The causes for macroglossia can be divided into congenital, hereditary, and acquired. The congenital causes for macroglossia are vascular malformations, lymphangioma, hemangioma, hemihyperplasia, cretinism, Beckwith-Wiedemann syndrome, Down syndrome, Duchenne muscular dystrophy, mucopolysaccharide, neurofibromatosis type 1, and multiple endocrine neoplasia. The acquired causes for macroglossia are edentulous patients, amyloidosis, myxedema, acromegaly, angioedema, myasthenia gravis, amyotrophic lateral sclerosis. Macroglossia can be classified into true macroglossia and pseudomacroglossia. In true macroglossia, the physical examination of the oral cavity and head morphology is helpful to deduce true macroglossia from pseudomacroglossia. Pseudomacroglossia. Severe retrognathia and usually small maxillary or mandibular size will depict or will show the tongue as a smaller structure due to the surroundings influence. In addition, check tongue tone and mobility to rule out simple atonia or hypotonia, indicating poor posturing of the tongue, as it is commonly observed in Down syndrome. Clinical features. Most commonly seen in children. It has the following features, namely noisy breathing, drooling, difficulty in eating, and the tongue enlargement may result in lisping speech, and the pressure against the mandible and teeth can produce crenated lateral border to the tongue, open bite, and mandibular prognathism. Treatment. In symptomatic patient, reduction glossectomy is done. This picture depicts macroglossia. Ankyloglossia. Ankyloglossia is also known as tongue tie. Here we could find short, thick lingual frenum resulting in limitation of tongue movement. It has male predilection and the tongue is fused to the floor of the mouth and may develop an anterior open bite and may result in speech defect. The treatment for ankyloglossia are frenectomy and frenuloplasty. This is a picture depicting ankyloglossia or tongue tie. The next developmental disturbance of tongue is fissured tongue, which means presence of numerous grooves or fissures on the dorsal surface of the tongue. Etiology. Polygenic trait or autosomal dominant trait with incomplete penetrance. Clinical features. Multiple grooves or furrows ranging from 2 to 6 mm in depth. It divides the tongue into multiple separate islands. It is usually asymptomatic, although some complaints of mild burning or soreness. It has strong association with geographic tongue, and it is a component of Melkerson-Rosenthal syndrome. The histological features of Fisher tongue are hyperplastic rete ridges and loss of keratin hairs on the surface of filiform papillae. There is no specific treatment for Fisher tongue, although regular brushing of the fissures in the tongue is suggested because it will reduce the lodgement of the food and bacteria and all the debris in the fissures, so that foul smelling or all other manifestations can be prevented. This picture shows Fisher tongue. The next developmental disturbance of the tongue is hairy tongue. Hairy tongue is characterized by the marked accumulation of keratin on the filiform papillae of the dorsal tongue, resulting in a hair-like appearance. Etiology: heavy smokers, general debilitation, poor oral hygiene, drugs that induce xerostomia, radiotherapy to head and neck. Clinical features. The most common site for hairy tongue is midline anterior to the circumvallar papillae. The elongated papillae are usually brown, yellow, or black as a result of growth of pigment producing bacteria or staining from tobacco and food. Thick and matted appearance is a characteristic feature of hairy tongue, and we also find oral malodor. The treatment for hairy tongue is the predisposing factors should be eliminated, and periodic scraping or brushing must be done, and we can also use some keratolytic agents. This picture depicts hairy tongue. Thank you for watching.